Welcome, hello, and good morning, and welcome again to the third and final webinar from our Beyond Blood Sugar, Improving Kidney and Lipid Care in Diabetes. This day, we're going to be presenting a case-based webinar, and this is hosted by the Office of the Lifelong Learning and Physician Learning Program at the University of Alberta. During this session, we will present 3 cases for discussion. Since we are discussing your dilemmas and your experience with patients in care, we request that you avoid mentioning identifiable information such as names and locations to protect privacy. My name is Donna Manca. I am a professor emeritus, a family physician, network director of the Northern Alberta Primary Care Research Network, the Director of Quality Improvement in the Department of Family Medicine, as well as the Medical Director in the Physician Learning Program and L3 program. The Physician Learning Program and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for our patients. First off, I'd like to present a land acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Stoney, Dene, Iroquois, and Ojibwe lands that are all known as part of Treaties 6, 7, 8, the homeland of the Métis as well. The University of Alberta respects the sovereignty, lands, histories, language, knowledge systems, and cultures of all First Nations and Métis and Inuit nations. For housekeeping information, I would like to start to talk a little bit about the chat feature. We may ask you to use the chat feature and use it as we ask during the webinar. However, if you have questions about technical difficulties or lifelong learning programs and services, also use the chat feature. If you have a question for the speaker, use the question and answer feature of the webinar. Please review what has already been asked and upvote those questions that you'd like answered. We cannot guarantee that as panelists we'll be able to respond to all of your questions. We'll try our best. However, a recording of the webinar will also be sent by email to all of those who have registered. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. For information, visit the QR code that's illustrated. This activity has not been formally reviewed by the College of Family Physicians of Canada or the Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants can also earn additional credits by completing a linking to learning exercise. Today, we're very pleased to welcome Dr. Darren Lau and me. I'm Dr. Donna Manca. We're going to present an open discussions on you and your case dilemmas. Dr. Darren Lau is an assistant professor, a diabetologist, general internist, and clinical epidemiologist at the University of Alberta Hospital and the K Clinic. Darren is also an acting medical director in the Physician Lifelong Learning Program and the Physician Learning Program. Apart from his research in outcomes of medical therapy in adults with diabetes, he also enjoys sharing the newest and greatest things in diabetes care, and anyone will hear about it if you give him the time of day. So we're lucky to have him here today. Thank you very much for your time, and we'll move on to the presentation.
Hi all. Hi Donna. Thank you for that wonderful introduction. Here, let me just put the chat and the participant list up so I can see who's who. Yeah, I'm really excited about this session. I'm Darren Lau. If you haven't met me before, I'm a faculty member at the University of Alberta. I'm a general internal medicine physician. I do a lot of diabetes work in addition to my inpatient duties. And it's my pleasure to be here talking today. In our recent webinars, in this series of 3 webinars, we've talked about kidney care, optimizing cardio-kidney protection in adults with diabetes, and we've talked about management of dyslipidemia, including new tips and tricks and options we have for secondary risk reduction or risk reduction high-risk patients. Today, we're doing something very different, and I'm very excited about it. We're going to be talking about some real-life cases. I have 3 of them in this presentation. One of them was provided by one of you audience members, and I hope if you are here in the audience, you feel comfortable just saying a thing or two about the case. Just bear in mind that some details have been changed, some numbers have been jittered to protect patient confidentiality. These presentations do go up online, and so I wouldn't want people to be able to identify themselves. But yeah, I would love to hear from you. And then otherwise, we'll go through 2 other cases that are from my own practice and that I found absolutely fascinating. And with each case, we'll have an opportunity to take some feedback, some comments from the group about your feelings and thoughts and whether you've seen similar things. And then Donna will provide her thoughts and I'll provide my thoughts. And along the way, we'll have an opportunity to talk a little bit about some active research and some active work we're doing in the area of continuous glucose monitoring. Okay, let's advance the slides here. Whoops. All right. In terms of disclosures, I have not accepted any honoraria or fees for speaking. I don't know what a speaker is. I didn't know that must have been there on all the slides. I do not sit on any industry-funded advisory boards or consultancies. I am expecting to receive some dollars from Bayer to do a small amount of investigator-initiated research in the near future, although I have not seen those dollars yet. And I have no other conflicts of interest with industry.
And I have none to declare.
So the objectives of the day, we comment on your real-life diabetes challenges. Second, we're going to discuss the value of continuous glucose monitoring for helping resolve some of these diabetes dilemmas. And finally, I hope we have the opportunity to discuss the real-life challenges of managing diabetes in your practice. And it's important to remember, we're all in the same boat. But luckily, we keep getting more tools to help us out, and that's really important. I think the challenge of diabetes now is knowing what to do with all the tools that we have, right? Okay, let's jump in. Here's case number 1. This is a 74-year-old male with an A1C of greater than 10%. Now, the patient has a history of chronic kidney disease with EGFR 18 and 22, urine albumin and creatinine ratio about 69. This patient is a comorbid individual with Parkinson's disease, depression, resected colon cancer, and multiple related procedures. In terms of medication, they're currently taking insulin degludec, trade name Tresiba, at 64 units daily. Lispro, 6 units with meals. That goes by Admelog now. Linagliptin, 5 milligrams. Atorvastatin, sodium bicarbonate, as well as candesartan. In terms of what glucose data you have, he volunteers that his preprandial glucometer measurements are from 5.2 to 11.4, and 2-hour postprandial measurements go from 6.2 to 13.5 millimolar per liter. All right. I want to open it up for a bit of discussion. First of all, this is the case that was provided. Is that person here and able to speak in general terms to that challenge? Jennifer, go ahead and turn on your mic and say a thing or two. Oh, is that possible? Natasha, I don't know if you can.
Yeah.
Can you hear me?
Yes, we can. Thank you.
Yeah, so this patient, we have she'd been seeing or he had been seeing a an endocrinologist for a while, but there was lack of, I just don't think it clicked, and so it didn't really help anything. But we've been working for a long time on trying to improve her numbers, especially with her GFR being so terrible, or with his GFR being so terrible. I think it's just been a very big challenge. There's definitely um, some patient habits that are playing into this and sort of struggling with some behavioral change that's an issue, but kind of got stuck. I guess my big question here is the linagliptin actually doing anything now? And with her GFR like that, are there any other options?
What a challenging case. Um, Before we run over to Donna's thoughts, I wonder perhaps if any other members of the audience have seen similar patients or have some thoughts or suggestions for things that have worked. You can feel free to unmute and speak if you're able to, or you can go ahead and type in the chat. I think the chat's been enabled for everyone to type into. These cases are truly challenging. Go ahead, Manny. Yep. Why don't we start with Abmanyi?
Can you hear me?
Yep.
No, just for completion, I just want to, is the blood pressure normal? Just for, it's part of is the blood pressure fine?
The patient reports that at home it's fine. It's usually in the office kind of low 130s. So I would say borderline controlled for a diabetic. This patient has a nephrologist and they haven't been super concerned about their blood pressures either, but usually kind of around the low 130s mark.
Okay, perfect.
Yeah.
So just one comment. I think somebody mentioned the linagliptin. I don't think it's doing much. It's one of those medications that personally I don't use a lot. I mean, especially where numbers are not improving. I tend to sort of de-escalate, medication use. So one of those that I'll take out is Lina.
Yeah, that was my question too. I mean, that one I rarely prescribe these ones either. That one was a legacy medication that she's been on,
Right.
or he's been
That's
on
one
for
of
a
those
while.
medications you come across that somebody has been on it for a while, and then we just continue prescribing despite the fact that
Yeah.
we're seeing these numbers that are not changing.
Yeah, and
Now, one
that's
more question, Jennifer. This EGFR, is it a recent change or is it something she is had for quite a while?
the
Because
A1C.
sometimes, the reason I ask is because sometimes people suddenly get worse, but others have been like that forever, that kind of stuff.
It's been a long time. It recently has bumped up over 10%, but in the past, A1Cs have been usually in the 9% range. So as long as I've known her, I don't think she's ever, or they've ever had an A1C that's at target.
And then one more comment. One of the issues sometimes we encounter, with our nephrology colleagues is when we're looking after, patients that have diabetes and CKD, whatever the cause. So sometimes they don't care much about the diabetes for some reason. Not all of them, but some of them. They just leave it to the general practitioner or PCP to look after, which I find a little strange because a patient is a wall. It's not just kidneys, and we know kidneys are buggered up because of the diabetes, and therefore I would expect that our colleagues look at diabetes, as a priority in getting their kidneys better, not just treat the CKD. That's just a comment. It's an observation. It's not universal, but it's something I come across. In fact, at one time somebody says, "Oh, diabetes is not my business. It's for the PCP to look after." So I was a bit discouraged by those comments. I see them sometimes, but I think we need some. I don't want to say guidelines, but I mean we should expect this to be incorporated in their care, because obviously diabetes has a big say in this. Yes.
This is like,
you'd be surprised.
For this patient, this was definitely an issue. The the endocrinologist that was seeing her or seeing this patient, didn't seem to have the same kind of pressing concern I felt for the very out of target A1C combined with this GFR, and the nephrologist on every like letter I received back is please deal with her diabetes, right? So it's just there's yeah, the endocrinologist didn't really care about the kidneys, and the nephrologist like cared about the diabetes, but was like, it's not my problem. So it's been an interesting go with this patient.
I hear your frustrations, and from my perspective as general internist, you'd be surprised at how many internal medicine subspecialists out there are completely uncomfortable with the idea of making insulin adjustments. Okay, in the interest of time, I'm sorry, David. If you can put your comment in the chat, that'd be fantastic, and I'll read out the one comment that's already in the chat. Is the BMI high, and are their meals appropriate, or bigger meals may benefit from GLP-1? Actually, Jennifer, these are both good questions, and I had another question for you. Does the patient have any cognitive issues?
We haven't formally tested them for cognitive. My primary care nurse, my PCN nurse, does a lot of work with this couple, and there's definitely some understanding issues about, for a while when we had started the short-acting insulin, when they were checking their sugars and when they were taking the insulin and when they were eating was a little bit concerning. And this patient's very high risk she's had a couple of lows, and quite a high risk patient for having any lows. So yes, there's definitely some, we're titrating the insulins, but it's definitely, we're going reasonably slow because we're actually quite concerned about lows. So there's no official cognitive, but there's definitely sort of a barrier there for sure.
And David's question is, I think with all the comorbidities, the patient may benefit from goals of care discussions rather than looking at lab values. That is a very valid point. Thank you.
We have talked about that, and like she's still actually quite functional. Like they go out to the lake every summer, and it's an older couple, and they have like quite a robust life and kids and grandkids. So, this isn't a palliative situation by any stretch.
Understood. And Carol writes, high proportionate basal insulin to bolus. I really like that thought. We're going to run with that in a second. But before we do, I want to turn it over to Donna for her thoughts. Thank you for this case, Jennifer. It's clearly engendered a lot of thought and a lot of conversation. Donna, what do you think? Oh, let me click the slide.
Yeah, and there is a Q&A question about how frail the patient is. And of course, depending on frailty, we do, look at, how tight do we need to control the hemoglobin A1C, so all excellent reflections. I've had a few patients like this, and one in particular comes to mind, and what really does concern me is, I don't really know what's going on with their blood sugar. The patient I had involved was someone who lived on her own. She had family members that would help, some cognitive impairment. I really wasn't sure how accurate the blood sugars were when I was able to get them recorded. So then things come to mind, is the insulin appropriate? Are we having, low levels that are bumping up their blood sugar and making them hungry? All of these come to mind, and I mean, the nice thing nowadays that wasn't available when I was taking care of these patients is I couldn't order any continuous blood sugar monitoring. I mean, it just wasn't covered. And it is covered now. So that is an option where you can actually see what is going on. Looking at that medication, the gliptine, not really one I would use. I think there are better medications that you could use in place of that. And in the patient that I had, she wasn't on that, and I wouldn't have used that. It can react with ARBs. You can get quite a serious angioedema with it, and she is on that drug as well. So it may be good to move her off of it. The other options that I've had in my patient, and she had severe renal failure. She was obese, but she was eating okay. You know, there was no problem, so then the GLP receptor agonist, came as probably a better option to go with her. And but I was nervous, right? Because with the semaglutide, even though she's living alone and we're talking about giving needles, um, we're having someone come in the home to do that. Once a week is easy, but it's a once a week dose. So I was really worried that if I gave her, even a very low dose, that we're going to have problems for a week, right? So I decided to start with liraglutide, a daily, very low dose, and then titrated it up, and that was good. And then I did switch to the more weekly injectable. There are other considerations I've had reflecting on all the patients I've seen. There have been cases where I've had where patients were not eating and were underweight and that kind of thing. And then, these medications may not be an option, but there is the medication, the antidepressant medication that you can use, to help stimulate appetite. That wouldn't be in this case, but it is something that came to my mind. So those were my thoughts reflecting on this case.
I had some very similar thoughts. The advanced CKD does make things so challenging because some of our newer options that have made life a bit easier for us aren't options here. The eGFR is a bit too low for empagliflozin, which has labeling now for heart failure down to 20, or finerenone for that matter, although finerenone won't help with the A1C. I think clinical context is really important, and understanding that the patient is not palliative, of course, but I would be concerned about hypoglycemic episodes and the possibility of cognitive impairment. And we have great function right now. We want to continue that function, extend longevity, offer quality of life, but there is that risk that being more aggressive with therapy, we can actually cause harm if the patient has more hypos. And so I definitely wouldn't be targeting an A1C of 7.0%. 8.5% might be reasonable. We're still quite far from that. But there are a handful of patients in my practice where I have taken a straight up harm reduction approach. I seem to preside over their twice yearly A1C of 10%, and it's incredibly high, and I feel bad that it shows up in my labs. But I'm actually just happy that they haven't ended up in hospital with hyperglycemic episodes or hypos. And so, if, for example, one of the oldest patients I have with type 1 diabetes who was diagnosed when he was in his 70s now has some cognitive impairment, and there's only so much I can do. When you look at those blood sugars, they're highly variable. Some of them are right on target, 5-point sums, and some of them are up to 13s, preprandial and postprandial. So, if we were just to increase the total amount of insulin this patient is taking, you do run the risk of lows, so that's challenging. But I echo Donna's point. CGM can be a game changer here. Libre Link, can allow, sorry, that's a branded term, but there's that's the Abbott version. There's a Dexcom version as well, where family members can look at their loved ones' CGM on their phones as well. Can really help with family members chipping in and understanding what's happening and make insulin dosing a lot better. Linagliptin, I get that it was chosen because linagliptin has no renal dosing, so that's kind of nice. But here, yeah, I think it would be nicer to try a GLP-1 receptor agonist, and I would be okay using Sema. I guess you could use Lira as well, but Donna's point that it's the type 1 patients on GLP-1s and the CKD patients on GLP-1 that are at higher risk of those GI side effects. And even in the general population of adults with diabetes, when I start semaglutide, there's that 1 in 5 in my practice. I know in the trials it was closer to 1 in 10, right? Or lower, right? Like 5% discontinuation rate for GI side effects in the trials, right? But in my practice, it's a bit higher than that. And so, dosing low, going slow, including using off-label click counting doses to take very gentle step upwards can be really helpful for tolerance. And the issue is with patients with more comorbidities, you know, oral intake and weight loss is such a common problem too, right? But it's definitely worth trying. GLP-1 receptor agonist can be a bit of an off-ramp here. If you do start a GLP-1 receptor agonist, just remember that it may change the absorption of other oral medications. I know this patient's not actually on Parkinson meds, but if they were, you may want to watch out for their efficacy here because of delayed absorption. Those were a couple of thoughts, and I thought I would extend the case a little bit more. So this is a CGM. This is not from this patient. This is hypothetical. All right. But let's say you were to any research studies you could look for. Romana, let's put a pin in that one for the end. That's a good, I like that question. Put a pin in that one for the end. But let's say we were to throw this patient on a CGM, and this is, you know, an example of a CGM I've had in a similar patient. Any comments on this CGM? You know, evening snacking. Okay, okay. Carol, you know, I'm curious, evening snacking, there is definitely a lot of carb intake happening here. The question is, why do we think this patient has evening snacking? I'm picking on you, Carol, because I think you know the answer to this particular CGM. Okay, Romana says needs basal dose increased. Oh, I like it. This is a high yield CGM. Fear of lows overnight. Yes, you really worry about that when you see this CGM. Okay, the key thing is look at the amount of variability here. And on some days, first thing in the morning, she touches the low line. And remember, you know, the 5% tails on these AGPs are truncated. So we probably do have some values in the red. In fact, if we go to the dailies, we do. Here are the dailies. Here are the dailies, okay? So this is a classic CGM indicating over basalization, which is, Carol, the point that you had mentioned earlier. Again, this is hypothetical. Jennifer, this actually has nothing to do with your patient. It's just to illustrate you know, point of care. This is over basalization, and the tip-off is that there's a very decent downward trend in blood sugars overnight when the patient is not eating and is not taking short-acting insulin. So, you know, this usually indicates that the basal insulin is a bit too much. And sometimes it's normal to come down if your blood sugar is 20, right? You're going to urinate some sugar, metabolize it, etc. But it definitely shouldn't go down to the point where you actually have a true low, right? And so what's probably happening here is the patient has that fear of this low and is snacking, driving their blood sugars up. So they're literally feeding the insulin. They may be snacking at bedtime, out of anxiety and fear of lows as opposed to because they want to or feel hungry. And when that happens, we call that feeding the insulin. And very often providers will increase their insulin doses, and that might not be the right answer. Actually, the right answer might be to reduce certain insulin doses to curb the need to feed the insulin and to curb the need to overcorrect. Yes, overcorrect the lows. But, you know, when you wake up feeling like this, I totally understand. You know, this is heart-stoppingly symptomatic, right? Like people feel this, and yeah, that panic sets in, right? So yeah, overcorrection is an issue too. Needs a higher low glucose alert. Yes. Or alternatively, you know, Dexcom CGM is also funded by Blue Cross now, and the Dexcom has predictive low alerts. So if it thinks you're going to drop below the low threshold, it will actually give you an earlier alert, which is kind of cool. That's a unique feature of the Dexcom G7 product, right? Yeah, so CGM is really helpful for that. Okay, over basalization, some warning signs. You know, if we get to the point where at 0.5 units per kilo all in basal insulin, you know, you got to wonder if someone needs to have prandial insulin put on. The usual dosing for type 2 diabetes is total daily dose of 0.5 to 0.6 units per kilo split half and half basal bolus, right? Although lots of patients have a lot more insulin resistance. But other clues include morning target being reached, but having severe highs before going to bed. You wonder if they skip dinner, skip a snack, and they actually go to bed with a normal blood sugar, are they going to crash in the morning? Overnight hypos or patient anxieties about having to feed the insulin. Those are all clues. And again, in this case, yeah, what a challenging case, right? We have a couple of options to nibble here. CGM could be high yield, enlisting family, but sometimes accepting harm reduction is the right approach, right? Yeah. Jennifer, I don't know if that's incredibly helpful for you. What a good case, though. Okay. In the interest of time, I'm going to move forward. So I want to talk a little bit about continuous glucose monitoring in your practice, how to approach continuous glucose monitoring. We'll go through this really quick. If you have any questions, please pop them in the chat or in the QA for the end here. So this is how I interpret CGM output. I like it when we get these nice ambulatory glucose reports. I mean, if the patient isn't linked into the cloud, they have to print these off for you or send you the PDFs. But if they are linked into the cloud, you can pop these on your screen by logging into Dexcom Clarity or Abbott's Libre View app, for example. But how do you read this? This is a very standardized reporting format. There's international guidelines about this. Step one, have a look at the sensor wear indicator. The goal is you have 14 days of coverage with over 70% data captured during that time. That's just for data adequacy. Step two, CGM enables time in range metrics. So this is the percent of every day, of the minutes of every day that a patient spends with blood sugars in a certain range on average, okay? And we have unique targets based on time and range. For example, a time in that green zone between roughly 4 and 10 of greater than 70% of their waking minutes in a week is roughly equivalent to an A1C of 7.0%. So that's our common target for time and range, is to have 70% time and range. About a 1% change in time and range is equal to about 15 minutes. So if it's 1% of time in hypoglycemia, that's actually an average of 15 minutes every day with blood sugars less than 4. If it's 3%, that's an average of 45 minutes every day with blood sugars less than 4. So that's how you interpret that. The clinically meaningfully important difference for time and range is about 5%. There's a glucose management indicator. This number really is just the A1C the device thinks the patient would have if you were to measure their A1C right now, and if their blood sugar control over the last 2 weeks was representative of the whole of the last 3 months. I actually do find this pretty accurate for stable patients. And again, this is a figure showing the specific targets for time and range. So for most patients, we're targeting a time and target range of 70%. But for your older individuals where you're targeting, A1C of 8.5%, we might look for a time and target range of 50%. But we would definitely want to minimize hypoglycemia. So we want that to be less than 1%, okay? And these are all in the Diabetes Canada guidelines. This number here is the coefficient of variation. It indicates the amount of spread from day to day at that time. And we like to see the CV less than 0.35. If it's really high, that indicates, well, there's a lot of meal variability or patients are, on and off about taking their medications. And then here's the AGP. There is, of course, the central tendency, which is the median of all measurements at that time of day over the last couple of weeks. There's an interquartile range band, and the lighter shading is the 5 to 95th percentile range, again, with the tails omitted. So just watch out for that. I always look at the daily logs after that. That's where I really, I come up with some hypotheses looking at the overall picture, and I test them with the daily log. The nice thing is you can see when patients looked at their blood sugars, these little circles, what they knew, when they knew it. That's really kind of cool. And if they're on about it, they can, you'll have their insulin dosing as well, but only if they're on about inputting that data. And sometimes they can input their carbs in their meal notes too. Okay, approach to AGP interpretation. We start by looking at sensor wear and activity. We look for hypoglycemia. If we see it, we fix that. We look for hyperglycemia. If we see it, we fix that. And then we look at variability. If we see it, we give the patient some tips on, reducing the amount of variability they see to help with predictability and insulin dosing. And this is a really nice paper by Dupas et al. Again, we'll have this in a PDF out to you at the end, in about a week's time, that just goes through the differential diagnosis for all of these steps and the steps you might look at, things you might adjust on the basis of what you see. I want to highlight that PLP, we as a group have developed a patient-oriented toolkit. There's a video, there's a PDF guide, and the whole point of this is that individuals starting on CGM often use it to replace a glucometer. So they use it as a dumb glucometer. It's like, oh, my blood sugar is this. Okay, I'll give some insulin. Oh, it's a bit high. I don't know. But the real value of CGM is that you look at the AGP, you look at reports like this and you think, okay, that went well, or that could be better. What can I do better next week? What can I change next week? So it's that element of retrospection and then forward thinking and then practice or behavior change and sustaining it. That's the real game changer for CGM. And that, I think, is the next level, the level we want to get our patients to, instead of just using CGM as glucometer replacement. And so these tools are designed to start patients on that journey. So have a look at them, albertaplp.ca /CGM guide. Okay. All right, here's the next case. This is a 72-year-old male with an A1C of 7.4%. He's an otherwise healthy individual who was a runner, and he is somewhat bothered by decreasing endurance for his sport as he ages. His last A1C was 7.4%, and he wants to optimize his diabetes. He is very careful about eating healthy foods, including antioxidants and whole grains. Here are his medications. He's a retired engineer. He plays guitar in a band. He wants to avoid insulin. He doesn't really like the idea of more medications. He hates the handful he has to take already. Okay. Let's go to any thoughts from the audience. This case is a quick one. In the interest of time, I want to save a bit of time for the last case, which I think is really much more involved. So in the interest of time, maybe perhaps I'll let Donna share her thoughts on the case. Is that okay, Donna?
Yeah, that works. I often have patients tell me they eat healthy, or pretty well all my patients tell me they have a really healthy diet. And early in practice, I thought maybe they did, right? But there's so much fad diets out there, and people think they're eating really well when all they're eating are carbs. In the last year, I had a couple friends of mine that told me they found this really healthy diet and they were doing so good. And then they were diagnosed with diabetes. And I said, well, what diet is that? It was choosing. And they had attended a conference or something, and they choosed for a week, and they felt the best they ever felt. And that, in their mind, was the indicator that this is a really good diet, not only from the propaganda that the juicer sellers were providing them. And I sort of suggested, well, maybe, when you choose, you remove all that good fiber and your blood sugars go up. And maybe what makes you feel good is a sugar high, So sometimes what patients feel are not necessarily an indication of health. And I think, that can be a problem. So with this fellow, I'd really wonder, what is he eating? I hear patients using, eating mostly just steel cut oats and nothing else, and just all carbs, right? So, and they can be very hesitant in sharing what they eat, because I find a lot of times they don't think I know what is a good diet, and they do. And that I might criticize their good diet that they know is good because they felt good on it. So it's sort of getting that trust and relationship going. And then I found, in these cases, sometimes that continuous glucose monitoring can actually inform them a little bit better about what the diets are doing to their blood sugar. So they can say, you don't need to take my word for it. There are ways you can look at, how good your diet is for your blood sugar. And this might be a situation with this individual where his lifestyle could be actually, despite him thinking it's healthy, may not be healthy for him.
This is truly one of my patients, and he, when I went over his diet, I found exactly that. He did have, he thought he was eating very healthy, and it was a lot of these steel cut oats. And we made some I just gave him some little tips. I said, moderate your carbohydrate intake and make sure that you're also getting a bit of protein fat with your breakfast, which was the meal that he was worried the most about. So eggs, a bit of cheese, a bit of peanut butter with breakfast. And he was using natural honey as a sweetener, on 1108, a tablespoon of honey is the same as 3 packets of table sugar. That was mind-blowing for him. And that's another common thing is the sauces, right? A little bit of sauce on top of ribs, for example, honey garlic or whatnot, really can destroy your blood sugars. If depending on everybody's response to the protein, the fat, and the ribs too, right? So people have very idiosyncratic responses, right? That might level that out. But the one thing we did was we put him on CGM. He's not on insulin. He didn't have funding for it, but he went on it anyways. And this is the CGM I got back from him, which is beautiful. GMI of 6.4%, right? Great glucose variability. Yeah, as soon as he eats, it goes up, but overall stays in pretty good range. And this is because he came back to clinic. He says, "Hey, doc, yeah, I added in those eggs. I added in that bit of cheese. It made all the difference." He was keeping track of it. He was adjusting his diet to fiddle with that. And, despite not being on insulin and having to find out-of-pocket ways of paying for it, he continues to be on CGM to this day. He really, really loved having that feedback. This is a randomized trial that Donna, myself, Rose Young, and some others, Rose Young's one of the endocrinologists at the university, we've just completed this. We published the main paper from this in October. This is called IQ. We randomized 105 patients with type 2 diabetes, high A1C, but not on insulin. And we randomized them 1-to-1. One group got 6 weeks of CGM with some diabetes education. The other group only got the diabetes education, so enhanced usual care. And then the main outcome was A1C at 12 weeks. And what we found was that CGM reduced HbA1c, with baseline adjustment by up to 0.65%. 0.65% average baseline adjusted reduction in HbA1c, more in CGM than was seen in the usual care group. And CGM, again, baseline adjusted regression, nearly doubled the chance of achieving an A1C reduction of 0.5% or greater, with that risk ratio being 1.92, which makes it as good as starting a new diabetes medications. CGM also reduced diabetes distress, specifically on the food-related and emotional subscales of the paid instrument that we were using. So, and you know what, medications don't necessarily do that. And so there is some benefit for using CGM in patients without diabetes to get their without insulin, not on insulin, to get their blood sugar. Okay. Case 3. Now this one is a bit involved. Okay, here we go. This is a 79-year-old male with an A1C of 9.6%. This is a former executive. He's referred for high insulin doses. His A1C of 9.6%, and here's what he's on. Basaglar, 50 units. Aspart, 30 units 3 times a day with meals. Sema was recently increased from 0.25 to 0.5 milligrams weekly. He tried Canna, 300 milligrams, and had urinary symptoms and yeast infections. And he comes to clinic, you ask him, well, what are your blood sugars? Can't really tell you. He ballparks here, he ballparks there, maybe this. It's not really something you feel you can trust. How many times have we seen this in clinic? Comments from the group. How do we handle this? I think these are pretty big insulin doses for someone who can't tell me what his blood sugars are. All right, let's see. Carol says, CGM, consider continuing increase the SEMA focus on post-meal blood sugars. Yeah, that's fair. You know what? The basal to aspart ratio ain't too bad. I mean, 90 units of aspart, 50 unit total daily dose of Basaglar. I mean, these could just be too much. We don't know, but fair enough. Yeah, focus on post-meal blood sugars. But Romana, yeah, we definitely need more blood sugar data. Okay. So we throw a CGM on. Donna's thoughts. Okay, Donna, what are your thoughts?
Yeah, we don't know what blood sugars are going on. And we get so many patients. I mean, I've had my blind diabetics, who live with a spouse that is terrified of measuring their blood sugars and not doing it. And I think sometimes they come in and they make up stories about things are because they don't want to disappoint me, which is really difficult, So we don't know what's going on with this guy. And I think the insulin could be, sometimes again, maybe it's too much insulin, for this guy. We don't know. And I like lots of data, and in these cases, again, I'd send them home and try to get them to do more blood sugars and capture it. And again, often they'd come back and it wasn't necessarily able to tell me what's really going on. They wouldn't capture it. So I think we're very lucky that these continuous glucose monitors are covered, in these insulin diabetics. Now the problem with that is actually getting them to get it on and the education in that. And a lot of us, we just don't have time. We can't do that in our practices. And the key really is that we've got others that we can rely on. I think the medications could definitely be optimized, certainly non-insulin medications that improve blood sugar without, aggravating his metabolic syndrome would be excellent, so again, trying to increase the SGLT2 and maybe adding on a GLP. So those are my thoughts.
Yeah. Now, Canna, 300 milligrams, is pretty hefty for an SGLT2 inhibitor, and he previously had urinary symptoms. But I will point out that Canna has the highest glucose uric effect, which tends to, in my practice, I don't think there's actually any evidence for formally establishing this, but in my practice, that does mean it's got the highest risk of having that orthostatic symptoms and genital mycotic infections. And I do find that patients on 300 of Canna might be able to tolerate 150 of Canna or, for example, 10 of DAPA. So that, that is another option as well, is to retrial a different SGLT2 inhibitor or a lower dose. Or, as Carol says, go up on the SEMA. But here's the funny thing. We actually did all of this. I put this patient on a CGM. Before we go there, I guess, there's another thought too. There's also tirzepatide, a new GLP-1 receptor plus GIP agonist on market that in head-to-head trials in diabetes patients is superior to SEMA for weight reduction and for A1C lowering at the 1.0 milligram diabetes dose. But CVOT, so cardiovascular outcome trial of tirzepatide, is still cooking. And funding for tirzepatide is private insurance only right now. And it also, I'm not aware that they've come out with their pen formulation yet. Maybe they have, I'm not sure. That was, supposed to happen. Last I heard, they were on vial and syringe, so that's very challenging. But in select patients, who have maxed out their SEMA or with benefits, tirzepatide could be a good option too. But anyways, of course, bearing in mind that SEMA still has the better cardiovascular outcomes data. So in your high-risk cardiovascular patients, depending on whether, you stick with the evidence, SEMA might be a better option there. But anyways, okay. So I did put a continuous glucose monitor on him, and lo and behold, this is what I get. Yeah, he's hyper. Yeah, there's a huge amount of variability as soon as he eats. Overnight, though, he's pretty good. Time and target range of what, 68%? GMI of 6.9%? How does this stack up with the man who is on 50 of Basaglar, 30, 30, 30 of Admelog with meals and has an A1C of 9.6%? I did a double take. Is this the right individual? Was the app giving me someone else's data? This was bizarre. And then I looked at the daily logs and whoo, jaw-dropping. Okay. Thoughts from the audience. We're running short on time, I recognize, but we'll take some quick thoughts from the audience on this CGM. And then alcohol. Oh, that's a good point. We didn't talk about that, but yeah, a lot of variability can be induced by alcohol for sure. In this case, that was not the case. Insulin resistant. Interesting. See, I actually think the opposite. I thought the patient would be insulin resistant based on how much insulin he was requiring and still having an A1C of 9.6%. Is he giving his insulin correctly? Hey, there we go, Leanne. I personally think you've hit it on the nail. Okay. So there's I always think differentially. What's the differential diagnosis from one I see? Well, it could be over-basalization. You see that, but you see some lows, but that's not the usual timing for a low from over-basalization. Usually you see that later on in the early hours of the morning. And usually with over-basalization, you have a downward trend overnight, okay? It could be semaglutide effect. He went from 0.25 to 0.5. Maybe he's a super responder. But you know what? Here's the big tip off for me. Here's what the big tip off was for me. If you look at the one instance on this CGM where he documented an insulin dose, you'll see that he gave himself 10 units of insulin because he became aware that his blood sugars were, so this is the second daily log here. His blood sugars were high. He gave himself 10 units of insulin just after 4 p.m. This is probably after he ate as opposed to before he ate something. And that 10 units did him wonders. It dropped his blood sugars back into the normal range. Wait a second. This is a man who was taking 30 units of aspart 3 times a day with meals, or prescribed 30 units of aspart 3 times a day with meals, right? Right? So now the point here is I'm not sure he was ever taking 30 units of aspart 3 times a day with meals because he took 10 on this one day. Can you imagine if he had taken 30, what would have happened to his blood sugars? I think this is a case of insulin non-adherence. And in fact, once he put the sensor on and he was getting reliable measurements and the alarms were going off and telling him to check and take his insulin, all of a sudden you had a lot of low blood sugars that were unmasked. His insulin sensitivity is actually far better than it was originally thought. So I thought this was just insulin post-meal, especially separate. Yes, there's that one example of that for sure. Yeah, that 10 units was given after the insulin, after the blood sugars have already begun to go up. So what I love about CGM is that we get this, if you really dive into the daily logs, you can have this fantastic insight into what patients knew and when they knew it and how they responded to that. And patients have often forgotten about it by then. And you cue them and it's like, oh yeah, that did happen, right? And so, I mean, that degree of insight, it takes time. It takes time. And so Donna's right. You need to get the team members involved, to help train patients on how to do the same introspection, retrospection, right? But boy, if you can pull it off, it can do wonders. And just imagine, I mean, this interpretation is based on having all this overnight data, like this patient was just not able to do the finger sticks, right? Okay, so this patient, how it went was we ended up, I did end up putting him on DAPA-10. He tolerated it well. The SEMA was up titrated to 1.0. There were major cuts to his insulin doses. And, it wasn't all me. He actually did have 2 hospitalizations for urinary issues and hip issues. And during those hospital stays, there were progressive downward decreases in his insulin doses. And he ended up on Basaglar 14 units, Admelog 10 to 15 units with meals. Holy moly, that's so much less than he was on before, or than he was prescribed before, right? Right? And this is a CGM now, and it's muy bieno. When I last saw him, this is what I saw. And the only thing that I had to suggest was exactly as Carol mentioned. Look at that. If you look at the second daily log, you can see the 14.9, the 14.0, and then that's when he became aware of it. You can see the circles there. He dosed himself insulin. Look, he almost ran hypo at 2 in the morning, So yeah, that was exactly the advice I offered him. You got to remember to dose your insulin before you eat based on your preprandial blood sugars, because if you dose it late, it's going to go too long. If you dose it late, you're going to dose too high, right? So, but he's actually doing really well from that perspective. So I was quite gratified to see that. Okay, Donna, I don't know if you had any last thoughts about that particular case.
Yeah. Again, it can be unmasked. In my practice, where I'd find out about this would often be if they wound up in hospital, and then what we gave them in the hospital completely did not match what what they were saying they were taking at home. But the key, I think, is that we have resources that we can draw on. We have teams, with nurse practitioners and other supports and allied health workers. It really is a community that raises a child. It's a community that raises our diabetics, patients living with diabetes. So that's really where we benefit. And I think it can be a problem in settings where we don't have those resources. So those are my last thoughts.
To summarize, your diabetes dilemmas. So I think during the course of these 3 cases, we've highlighted the importance of exploring the personal context with adults with diabetes to understand what's going on in their lives and what their priorities are. We've talked about several key pitfalls to watch out for. So over-basalization, that one happens because we always just start with the basal and we push and push and push on the basal. But we have to remember that sometimes the morning blood sugars aren't in target range because the evening blood sugars are really high, and then you got to deal with the supper time, right? We've talked about the pitfall of healthy diet and the importance of exploring that, and then the pitfalls of non-adherence or incorrect insulin administration. I've had patients administering consistently into lumps in their arms. God knows what insulin they're actually getting when you administer into a fat lump, right? But do consider your person-centered targets, including harm reduction approaches to diabetes in frail or comorbid individuals. And finally, continuous glucose monitoring can be a game changer that helps you navigate these dilemmas, that can provide extra insight, that can empower patients and their families. And it is now funded publicly for adults with Blue Cross benefits. And so that's most adults age over 65 on multiple daily doses of insulin. I really do consider this a form of digital health. Again, here's a plug for our CGM toolkit. It is available. This website will improve. There's going to be a video. It's going to be uploaded. There's going to be some more materials. So keep coming back to it. It is a work in progress. albertaplp.ca/CGM guide. And there's a screenshot of the guide, really nice and straightforward for patients to have a look at, just to help foment that retrospection and forward action planning. All right, and that is it for us. Wondering if you have any questions or concerns before we close our morning. Let's see if there's anything in the Q&A.
There was one question in the Q&A with the first patient regarding how much tight control of the hemoglobin A1C is required, depending on how frail the patient is. And I think there was a nice slide that you presented on the continuous glucose monitoring with different patients, what sort of targets you would consider. And I think that was a really good comment to come in from our attendee. So when you're looking at a patient that is frail or older or higher risk, of course you're going to, go with a lower hemoglobin A1C target.
Does anyone remember the Accord trial? Like we have medications now. You put someone on a GLP receptor agonist, and most people have a middle-of-the-road response. Some people have no response. Some people have serious side effects. But a decent number of people actually are super responders, and they see their weight melt away, their insulin requirements go down. Sometimes their A1C drops into the 6s, right? And I remember at first when I saw that happen, I was like, ooh, am I doing people harm? Because the Accord trial, which was published in the 2000s, showed that targeting an A1C of 6.5% actually increased mortality. Right? And so there's been a lot of debate about whether you can push A1Cs too low. But in the Accord trial, the subgroup analysis suggested that it was those individuals who were randomized to intensive care who didn't get to 6.5%, where the protocol called for physicians to keep pushing and pushing with insulin and glycoside and these things. Those were the patients that had the higher risk of mortality. And so my overall feeling is that if I can get that A1C down as a happy coincidence of putting people on medications that are good for them, I'm going to go for it, right? If it's at the risk of hypos and increasing insulin and weight gain, it might not be worthwhile, right? But, if they have heart disease and I put them on a GLP for the heart benefit and their A1C drops below 7.0 and I get to reduce their insulin doses, that's the way to go. So it's a funny thing. A1C targets for me are really dependent on, overall functional status and comorbidities and side effect concerns, but also how easily I can get there. And yeah, I'm happy to target a lower A1C if I can get there easily. But if I have to work really hard for it and I worry about putting the patient at risk, that target just goes up, right? It's a moving target. I hope that helps answer your question.
Now, I don't see any other questions. So I would really like to thank everyone for your great participation, and Darren as well. It really is a team effort in the care that we provide to our patients. With these webinars, we really appreciate your feedback, and it does help us, moving forward in future as well with what sort of presentations we do and improving them as much as we can. I would like to remind people that there is an upcoming webinar on March the 13th, and that will be on cardiovascular issues in primary care. So look for that, and attend those. And again, fill in your feedback. This helps us with what we're going to present in future and in improving what we do present. So thank you again.